Hello, everybody. Welcome back to the Incubator Podcast. We are live at Hot Topics in Neonatology, and we are joined by our next guest, Dr. Amit Mukerji. Amit, thank you so much for dropping by.
Thank you for having me.
You are part of the delegation from McMaster University who is here at Hot Topics. You are a neonatologist and associate professor in pediatrics. You have a very interesting session at Hot Topics talking about high CPAP pressures in preterm neonates. We were just having a conversation not too long ago with Risha Bhatia about the ECLA trial and talking about like the pressures they were using after extubation. But I feel like PEEP has been sort of the go-to thing for us as neonatologists, and yet we're always very afraid of going high. So what are some of the lessons you want to leave the audience with at Hot Topics about how to judiciously use an adequate amount of positive end expiratory pressure?
Yeah, thank you. And that's an important question, and I've been thinking about it for a number of years now since my fellowship days. And during my fellowship in Toronto, what struck me was that at that time, CPAP was really relegated to 5 to 8 centimeters of water. And I think in many centers, that's still the case. But when we moved to NIPPV, and at that time, we were using a lot of nasal high-frequency ventilation. And I felt that clinicians in general were more comfortable with higher pressures when we're using different modes. And that's kind of sparked the question that why is it the case that we're uncomfortable with using PEEPs of 9 or 10 or 11 on CPAP, but we're comfortable with those pressures, or really the equivalent of those mean airway pressures on NIPPV high frequency.
You're so right. I'm just
when you think about it,
using NIV, you're increasing your mean airway
or
pressure.
when you're using high frequency and you're leaving a mean airway pressure of 12, you're kind of on a constant pressure of 12, which is kind of equivalent of being on a PEEP of 12. So yeah, you're absolutely right.
Yeah, and then if you think about some of the pros and cons and of the various non-invasive modes. So for instance, with NIPPV, you get these spikes in your pressure. And in most applications, as we know, they're not really synchronized with babies' efforts. So it does raise the question of, how much of that air is going into the stomach versus really being delivered to the lungs. And as we know, there's quite a bit of data that those non-synchronized breaths, especially, they don't actually yield a whole lot of effective or implied tidal volume. And I think anecdotally, we can also speak to experiences where we have seen, and I certainly have seen, where those NIPPV breaths lead to some abdominal distension and so on.
You don't say.
So
how many times have we had to examine a belly on the baby on the high and non-invasive pressures?
Yeah. So when I first joined at Mac, we as a unit gradually got more and more comfortable with use of CPAP at PEEPs of 10 or sometimes even higher in the occasional case. And whereas in most other places, a baby like that would be on NIPPV. So it kind of led to the natural question of how those modes would compare if you actually compare them at equivalent mean airway pressures. And that really sparked the question, and that's been the focus of my academic work. So we've done some retrospective data. We've done some national cohort studies as well. And this was really designed as a pilot trial, but where we attempted to look at if you use CPAP as an alternate to NIPPV, but using effectively those same mean airway pressures, what would be the outcomes? And that's kind of what led to this presentation here at the conference.
So tell us what you found.
Yeah, so this was a pilot trial. So we were focused on feasibility. And of course, in the pilot trial, you learned many lessons. We had, 2 major protocol updates, and we felt that as we modified the protocol, the adherence and the compliance to the protocol improved. So lots of lessons that we learned just by doing the pilot and addressing what's the best way to answer the question if we were to do this in a larger scale. But yet we had 100 patients randomized in the study. And from a clinical outcomes point of view, what we found is that failure with high CPAP is higher. And that failure was defined as either going to an alternate mode of respiratory support, a non-invasive support, or exceeding predefined limits on either NIPPV or CPAP, intubation, mechanical ventilations, and crossovers. So when you define failure in that more general way, the failure risk is higher. But when you look at reintubation, which is arguably the more important clinical outcome of interest, there's actually very little difference when you use those modes. And I think that's probably, if we were to do a more definitive trial, that's the kind of way we would design it and aim for that.
What's interesting about your presentation is the fact that you're pretty much asking the audience to rethink completely how we look at these different modes. Where and what I like about it is that, again, I don't want to put words in your mouth, but it seems that when we're considering a transition from CPAP to non-invasive ventilation, we should understand that non-invasive ventilation makes things more complicated. And it might just be simpler to just let the people come up on straight CPAP, and you might have better outcomes. Is that correct?
That's right, yeah. So one of the entry paths into the study was that if CPAP of 8 was insufficient, then the default, as you said, is people go to NIPPV. Yeah. So that was one of the entry points into randomization, that if CPAP of 8 was not sufficient, we would either randomize to higher levels of CPAP or NIPPV. We'll, of course, need a much larger sample size eventually to kind of know the comparative effects of it. But, there are some data from other studies where we suggest that it's probably going to be equivalent. People worry about, for example, cardiac output and things like that. So we did a translational study where we crossed over patients from CPAP to NIPPV and vice versa using the same mean airway pressures and found that there's actually no impact on cardiac output. Yeah. So there's a lot more data that we have to acquire, but as you said, I mean, that's the kind of messaging ultimately we want to get to.
And what's interesting about it is that you mentioned that in one of your take-home points that the studies comparing CPAP and NIPPV do not do so. They compare different modes of ventilation, but do not do so at the same mean airway pressure. Right. So they're very, very different. Yeah. They're very different in nature, and that pretty much lends itself to the study you're conducting.
Yeah, and I think there's probably a subset of patients who benefit from the unique gas flow mechanisms of NIPPV or any other mode of non-invasive respiratory support. But I think the vast majority of patients will do just fine. It's a bit of speculation on my end, but that's what we have built the hypothesis upon. That for the vast majority of patients, if you use the right amount of CPAP pressures,
and you do it well,
they'll be just fine.
And if you do it, and you set it up correctly,
of course, yeah. I mean, that's a factor that's hugely important. But so we're really tackling the pressure selection point of view.
For sure.
But I think if that's done well, and like you said, all other application components of it are done well, then I think for most babies, the right amount of CPAP will be sufficient.
That's very exciting.
And I think there's always kind of two phases of clinical adoption. We need the data, and then we need like the buy-in, right? Yeah. So how have you overcome the kind of culture change in people?
Yeah, that's an important aspect because one of the things I've thought about, and it came up in this pilot trial, is that there's a higher level of failure with high CPAP. And I suspect that part of that is the culture that if CPAP doesn't work, we tend to go to NIPPV. And even in the context of this trial, I wondered how much of that culture of rescuing with NIPPV made folks want to go to NIPPV where even the higher level of CPAP would have been sufficient. But I think there was this anxiety, of course, that we've reached a certain level of CPAP and we don't want to go up anymore. That is going to take some time. I think forums like this are useful to kind of spread the knowledge. And I think collaborating with other centers that are using and are becoming comfortable with higher levels of CPAP is also going to be useful. And we have noticed in Canada that over the last 7-8 years, more and more centers have become more accustomed and more comfortable with the use of high CPAP pressures.
That's super helpful. Thank you, Amit, for dropping by the booth and for sharing this information. I guess we will be looking out for more data coming out of your center, and we'll see you around the conference hall. Thank you so much.
Thank you very much. Thank you both for having me.